history of the IOL is a classic improvement of medicine with the active cooperation of science and industry. It involves a reciprocating but overlapping evolutionary relationship of cataract removal technology with change in IOL design. The first intraocular lens implant was implanted by Sir Harold Ridley at St. Thomas's Hospital on 29th of November 1949. Ridley was inspired by the tolerance of British fighter pilots' eyes to plastic fragments lodged in them after their canopies made of polymethyl methacrylate had shattered. Over the last few decades came evolutionary changes in IOL design, fixation, IOL haptics. As demonstrated, ophthalmologists saw changes in material, emergence of foldable IOLs, aspheric IOLs, multifocal and toric IOLs, to name just a few. Yet, in all these major technological advancements, nobody till date has ever researched or documented the need for IOL power diopter labeling. Why would it be considered necessary? In most countries, ideally, phacosurgery is done with great transparency, live surgery with the IOL labels placed in the notes and the container given to the patient. However, due to mass-scale practice, cost-cutting trends to keep up with the competition or demands by patients and insurance companies, all the above measures may not be done. What is this proposed innovation? With all the above considerations, a new evolution in IOL design is proposed, which is innovative, revolutionary, and has never been implemented before. This will have a long-term impact not just on IOL companies trying to replicate US FDA-approved IOLs in shape and external design, and also clinical relevance regarding cross-correlation of post-operative refractive error and for further planning of the second eye surgery. This will have a long-term impact not just on IOL companies trying to replicate US FDA-approved IOLs in shape and external design, but also will be clinically relevant regarding cross-correlation of post-operative refractive error and future planning of the second eye surgery. Now, let us consider a clinical situation where the first eye was operated elsewhere with a residual power of -3 diopters. No previous records are available. Power of the IOL, let alone which brand, is totally unavailable. Biometry of the eye to be operated is 21 diopter. On dilating the pupil of the operated left eye, it can be seen that the intraocular lens is placed in the posterior chamber, but absolutely no other information is available. What is the solution? What if the previous diopter power was imprinted or etched on to the anterior surface of the IOL at the optic-haptic junction? If it showed a +24 diopter, it could have been correlated clinically that maybe a wrong biometry the first time may be the reason for the residual refractive error of -3 diopter in the left eye, which would make it easier for clinical correlation. Let us consider case number 2. A patient from a neighboring country who is pseudo-phakic in one eye, extremely happy with the first operation, wants an identical IOL in the fellow eye at a significantly lower cost. No records are available on the patient. On dilating the pupil, it is obvious a foldable single-piece IOL was used. What is the solution? What if this IOL was imprinted with the make, the brand and other details to help us to match it with the fellow eye? And lastly, consider case 3. A patient from another hospital comes for phacosurgery in an eye with a history of the latest technique of phacoemulsification with a popular imported brand of US FDA-approved IOL 1 year ago, and yet her visual outcome is not satisfactory with complaints of decreased vision, glare, dysphotopsia. On dilation, there is quiet pseudophakia with early posterior capsular opacification and evidence of an IOL which certainly does not appear to be a branded CE or US FDA approved one, with significant anterior capsular opacification as well. What could the solution be? In this case, what if This IOL was imprinted with the brand and other details to make identification and authentication easier, in spite of unavailable previous records. This will help in implanting the second eye with an IOL with more genuine credentials and prevention of early post-operative complaints. The IOL industry will be benefited as imprinting IOLs with the manufacturing name, logo, type and power will almost give an intraocular blueprint and authenticity, preventing unofficial duplication. The phaco surgeon will certainly be able to benefit as he will be able to duplicate the brand of IOL when asked for, or not to duplicate the same IOL if the patient is unhappy. Malpractice regarding implanting of a lower IOL will decrease. And the patient would benefit the most as he would be carrying his ophthalmic passport within his eye. In case of loss of records, IOL details may not be available. However, things will become evident on pupillary dilation. Medical tourism will be much easier as well. However, are there any practical drawbacks? Clinically, there may be poor visibility in a pseudophakic small eye and in cases of gross anterior capsular opacification. And of course, it might open up a Pandora's box whereby maligning other doctors by fellow colleagues or by patients alike regarding quality of IOL may be a problem in an unsophisticated scenario. In case of toric IOLs which correct astigmatism, the present markings are 3 to 4 dots placed at the optic-haptic junction in equidistant symmetry. As we all know, placing a toric IOL with correct alignment with the corneal markings becomes a surgical challenge in a small pupil or even a mid-dilated pupil. In the new proposed toric design, there ideally should be 4 dots on either optic-haptic junction at increasing distances, with the innermost dots at approximately 3.5 mm apart, so that in very small pupils they will still be visible and alignment of toric markings along the preferred corneal axis will still be possible. Ultimately, merger of both these innovations will lead to the best of both worlds. Ultimately, as ophthalmic surgeons, we will all strive for visual and optical clarity, transparency and honesty. And we owe it all to the vision, the brilliance and the perseverance of the father of the modern IOL, Sir Harold Ridley.